Good afternoon. I'd like to say thank you to the speakers that have spoken before me. Your insights have been so valuable, and I hope that my presentation can give a local context to the South Australian mental health sector and the accommodation needs of those experiencing mental illness in the state. I'd like to start with some quotes from the research that I undertook, and these are the quotes that resonated with me the most during the project and writing the report. They just assume you're going to be difficult when you present an emergency. The response is always over the top and disrespectful. If I could change anything, it would be the workers, so they would see me as a person and see my son as a person first. You have things done to you, and people talk about you rather than to you. We are counterintuitive. We wait for people to become unwell before we offer them assistance. Mental health consumers do not get a gold pass to anything, when they should be front of the queue for housing, income, education, and employment support. In 2014-15, approximately 18% of the South Australian population reported experiencing a long-term mental health issue or behavioural problem. The mental health sector in South Australia has continued to engage with international and national best practice approaches built from person-centred and recovery-oriented models. However, fragmentation is still evident in the South Australian STEP system of care. With the establishment of a South Australian Mental Health Commission to review the sector and provide recommendations to the state's next 5-year plan, this project was developed with the aim of constructively contributing to discussion around the sector's priority for reform. Via partnership through the Australian Centre for Community Services Research, the Don Dunstan Foundation and the Mental Health Coalition of South Australia, the project worked collaboratively with a range of sector stakeholders, consumers and carers to identify and explore these priorities, focusing on opportunities and barriers of cross-sector service integration. The value of sustainable accommodation combined with appropriate support during the recovery journey for those living with mental illness was also explored. One-to-one interviews were conducted with both stakeholders, consumers and carers. Focus groups were held, and these explored consumer and care experiences from a lived experience perspective. However, the most unique part about this project was the roundtable review process after we collected the data. We allowed participants from both the sector, consumers and carers to come back and provide their feedback on our recommendations and findings before constructing the final report. It was evident early in this research that the findings would not be new to those familiar with the mental health sector in South Australia. Instead, the project consolidated experiences of those that both work within and use the mental health system. The themes were not unexpected and in essence reflected documented concerns locally and nationally. This is significant. It suggests a strong narrative exists across the mental health sector about the necessary reforms in South Australia. It is notable, all participants in this study described feelings of frustration. These frustrations were around the continued discussion of themes that were hurdles in delivering a connected, person-centred system. This report identified 5 key themes and provided a set of recommendations about the desired reform priorities of those interviewed for the project. The fact that the roundtable discussions, all the interviews and the focus groups reiterated these themes clearly demonstrates the sector's desire to develop an evidence-based, collaborative approach to policy and practice. The key findings of the report were: the system is fragmented and unbalanced. There is a focus on clinical and acute approaches. The sector is risk-averse and there is a pervasive negative workforce culture towards consumers and carers. There is ongoing discrimination and stigmatisation, ineffective funding models, and a lack of appropriate measures, indicators and targets. And for most people in this room, that's probably not unexpected. Participants in this study advocated for the step-level collaborative person-centred system to continue, with consumer and carer voices being the most important elements in any future reform. Everyone I spoke to is eager to engage in the work to undertake this. The consistency of this narrative, from consumers to carers, government, non-government, clinical and psychosocial providers, speaks volumes as to the reform that must be undertaken in this state. The sector is frustrated and in many ways tired of advocating for a shift in focus to the potential and capacity of community-based services. The sector is calling for processes and policies to jigsaw the potential of community-based services with clinical and acute ones. So my first theme that I'd like to discuss is stepping up a system unbalanced. An integrated step system, particularly in relation to accommodation, was still supported by the people it was spoken to for this project. Participants spoke of the success of partnership models that wrap around consumers' social health needs, including HASP, the Housing and Accommodation Support Partnership Program, and IPRIS, the Individual Psychosocial Rehabilitation Support Service. Subacute levels of care were still advocated by people I spoke to, who proposed that subacute services must be implemented effectively to act as the step between acute and community-based services. Accordingly, this report recommends that the South Australian Government refrains from any reduction of service in the subacute area and instead seeks to refocus clarity on collaborative community-managed accommodation options. Despite this study revealing ongoing barriers to any door as the right door for consumers and carers, including segmented silos, a disproportional focus on one facet of service delivery, there was a desire to see a more flexible, connected and integrated system in this state. The optimism and willingness to engage in cross-sector partnership from the sector stakeholders I spoke to was evidence that the sector is ready to move towards this change. So from that theme, we go to recommendation 1, which is refocus on the effective implementation of a step system of care, rebalancing roles and resources within the mental health sector to best meet consumers at the level of need. Under each recommendation, we've provided a list of implementation steps, which I'll let you read through rather than read through them to you. And you will be able to access the report via the Don Dunstan website, the Flinders University website and the Mental Health Coalition website to further have a look at those steps. Key theme 2, strategy and reform connecting the parts. Participants in both the individual interviews and focus groups noted a lack of overall strategic direction in the mental health sector within South Australia. They hoped the South Australian Mental Health Commission would have the power and independence to both direct and link together policies, strategies and funding to facilitate a more connected, integrated system. It must be highlighted that perceived fragmentation and stagnation within South Australia was linked on a lack of focus on mental health since Stepping Up report came to its end of its lifespan in 2005, as well as an outdated mental health strategy. Furthermore, the impact of a lack of cohesion between state and federal funding and policies was identified as a concern for participants, and it's been noted by other speakers here today as well. This was underpinned by fear that a lack of forethought to ensure local reform jigsaws with federal reform, most notably the National Disability Insurance Scheme and response to the Mental Health Commission review of programs and services, could result in consumers falling through the gaps and experience ineffective and potentially harmful service provision. Staffing and service quality in the National Disability Insurance Scheme was also questioned and was described as a looming problem for mental health services in this state. Of interest, when the NDIS was raised with consumers and carers, most of them didn't understand the process and they didn't know whether they would be eligible. And it speaks volumes to the amount of education that's going to be required to get people into that system. Recommendation 2. Facilitate an integrated system. This system must be designed to effectively connect federal and state mental health funding and services, including the National Disability Service Scheme, the primary health networks, a well-resourced community-managed sector, consumers and carers. The third theme, fostering collaboration and integrating a person-first approach. This seems probably the most related to accommodation and accommodation options for those experiencing mental unwellness. And in this one, I heard client experiences of fear of not being able to maintain their accommodation, fear of not having accommodation when they left emergency services, fears of their family not wanting to take them back in, fears of losing support once they came out of programs that they were engaged with, so a fear of falling through the steps, that they were too steep. There is strong evidence to suggest there is a need to not only make available affordable and secure housing for those experiencing mental illness, as has already been noted here today, but for an approach that integrates these with collaborative services to engage more holistically to address the complex and interrelated needs in the sector. Consumers and carers in South Australia describe the current disconnect between their social health needs and their mental health services as negatively contributing to their ability to maintain their mental wellness. A cycle of entry into the system was highlighted in South Australia. This cycle was said to be triggered when consumers face difficulty, such as losing their accommodation, and an inability to access support at the early stages of mental illness, to engage with broader social welfare supports, such as accommodation, counselling, income support. This inability results in crisis, and the consumer presents at an emergency department. Once in the emergency department, they're either placed in an acute bed or discharged with medication. This was described as participants as fly in, fly out, and people believed that we had the highest rate of fly in and fly out in Australia. This dimension of acute and emergency departments was said to result in social exclusion, with sporadic episodes of acute facility-based care considered to contribute to the breakdown of relationships and impact consumers' abilities to sustain community connection, such as their accommodation. Support on discharge from emergency departments or an acute bed was described as non-existent in South Australia and was noted as a disservice to consumers and carers. This was also linked to a concern that consumers are unable to step between levels of supported accommodation due to the steep steps between acute and community-based services. And a lack of housing stock or options was noted as a primary barrier to effective flow through the system. And this has again been noted here today. We just don't have enough stock. The intensive care centres, the ICCs, were noted as being valuable within our system, but not operating as intended in South Australia. The main barrier to them operating intended was that they were considered to be too clinically led. An alternative model was proposed in which these facilities are contracted to non-government organisations and based on community psychosocial support with intensive clinical in-reach instead. It was suggested that this would reduce the reoccurring stepping up into acute and hospital services. The HAS program and the crisis respite centres were applauded for filling the gap between community and acute care to some degree. Both programs in South Australia operate on a collaborative, community-driven model with partnerships between non-government organisations, community housing providers and government community mental health teams providing integrated psychosocial and clinical supports. These insights reflect one of the strongest themes to emerge in this study, which was the recommendation for engagement with a more collaborative, integrated system that wraps around consumers, ensuring that any system is designed to address the range of social health needs that contribute to an individual's mental wellness was a key priority for those interviewed. And this loudly echoes previous research undertaken in this area. It also loudly echoes the stories we've heard today, that we need a system that reflects the whole of consumer, the integrated issues that they face, mental wellness and homelessness. Not only were collaborative partnerships in this project viewed as more capable of working with consumers at their level of need to achieve their recovery goals in a meaningful way, but they were proposed as the missing link to the various parts of a currently fragmented system of care. Those interviewed also proposed that we should reform how we can access these services. It was advocated that a person-first system would allow people to be referred by themselves, by their family, their GPs, their teachers, and the community services they're already engaged with to allow the any door, right door policy to take effect. Key theme 4, them and us, a roadblock to recovery. The stigma and discrimination described by participants throughout the mental health sector was alarming, and was probably the most disheartening part of doing this research. If not addressed, it will have detrimental effects on people's recovery journeys. Of particular importance was the identified negative workforce culture, identified by the sector and consumers and carers who participated in the study. Their experiences of work as being disengaged, disinterested, dismissive. And it was often attributed to these workers being in the job too long. Carers spoke of experiencing stigma towards themselves and those they care for, based on the fact that they identified as having a mental illness. For a more respectful and consumer-focused system to develop, there's an undeniable need to challenge ingrained stereotypes about mental illness within the mental health sector workforce. One of the most well advocated for ways among these interviews being able to do that was through the lived experience workforce and through peer work. And again, that's been highly recommended here today. There was advice that we should focus on specific peer work roles and expanding the lived workforce broadly, not just within the mental health sector, but across the sector, so into accommodation services. Participants advocated for embracing lived experience across all roles and consumers and carers enthusiastically supported advertising openly for those with lived experience to apply for jobs. It can be proposed that the implementation of a holistic, person-centred set of targets and measurements, reflecting a broad range of social health needs in addition to symptom cost-based efficiency indicators, would also contribute to reducing concerns and encourage the ongoing improvement of services. Although a best model of measurement wasn't identifiable in this research, it was suggested that a focus on the holistic wellbeing of individuals and a consideration for a community-driven mental health sector with collaborative, integrated approaches was needed. And that kind of approach has been advocated for in the Commission's review of services and programs. It must be noted that any measurements and targets cannot be developed, though, without the input and the equal input of those with mental illness and those that care for them. Recommendation 3. Develop outcomes and indicators that facilitate consumer-centred and recovery-oriented service delivery and collaborative approaches. Recommendation 4. Invest in training and facilitate the development of cross-sector knowledge and networks to challenge the stigma attached to mental illness by those in the workforce. Recommendation 5. Invest in engagement with and development of the lived experience workforce, which I think is probably my favourite recommendation of this project. The last theme, the consumer and carer voice, the missing piece. Despite this theme being last addressed today, and also the last addressed in the written report, it is unequivocally the most important. The ongoing frustrations experienced by consumers who feel stigmatised, unheard and undervalued as the experts of their own mental health was a theme interwoven throughout every interview, every focus group and the collaborative roundtables. Despite person-centred approaches being recognised as best practice internationally and a well-supported consumer movement that states nothing about us without us, those that volunteered for the study described a system that both ignored and actively silenced the voices of consumer and carers at micro and macro levels. A recognition that the sector does not adequately listen to or engage the voices of consumers and carers was a clear concern for the stakeholders spoken to for this project as well. And they agreed that this must be reviewed at all levels of the system. The need for reform to be undertaken in a collaborative, integrated manner across sectors via a co-design process with consumers and carers was clearly identified. And engaging consumer and carer participation in governance, decision-making as a standard rather than an add-on was highly recommended by those spoken to in this report. This contribution must be facilitated through appropriate training, support, remuneration, and respect. Possible benefits for both the consumer's recovery journey and cost efficiency to the system cannot be underestimated. Evidence in the accounts gathered, as well as in previous research and evaluation in the field, this is the way forward for this state. Of significant note, I did ask everyone the same question, and that question was, if you could give me one piece of advice for the Mental Health Commission in South Australia, what would that advice be? And this is paraphrasing, but every person pretty much gave me the same response. And that was, listen to those experiencing mental illness, listen to those who support them, and listen to the communities they are a part of. This speaks volumes about the necessity of a mental health system that not only provides quality, appropriate, balanced psychosocial and clinical services at both the community and acute levels, but to build the system on the express need of those that use it, the desires and the knowledge of the people it's intended to support. Recommendation 6. Develop stronger avenues to which the voices of consumers and carers can be heard, and place these at the centre of policy and service development. This research project provided insight into a sector that has the capacity and desire to change, yet still faces ongoing frustrations and roadblocks to achieving it. The potential for South Australia to become a leader in mental health is evident in the passion and commitment demonstrated by those who participated in this project. Consumers and carers are ready and must see on-the-ground change, to have their voices heard and both see and contribute to development of services and policy going forward. This policy and service must reflect their level of need at the appropriate time in a person-centred way. Through ongoing work to implement the recommendation of this report, and accordingly the priorities for those that use and work with the mental health sector, can prove that South Australia is on the right pathway to meaningful reform. I would like to propose the voices of those that I spoke to, particularly the consumers and carers, are calling for an end to the siloed approach to services in South Australia and develop of a more mature, connected mental health ecosystem that more holistically addresses social health needs in a connected way. I'd like to end with a statement or a quote that came from one participant, and it's the one that resonates the most with me throughout this study, and hopefully it resonates with you. I am more than my mental illness. Therefore, I need more than medication and a hospital bed. I need relationships, love, acceptance, a job, and a home. Without these, how could I ever be well? Thank you.
Now, I'm just going to check Slido. Does anybody from the floor have questions for Tanya? Oh, come on. Sorry, I can't find one on Slido. I'm not sure whether it's... Anybody questions for Tanya? One over in the corner.
You've seen that we're talking about crisis care and 24-hour emergency health care for these people, that they go for a while, they are successful, and all of a sudden government pull the money back from them.
From the centres or from the consumer?
They're really good for the consumer because
Yep.
we can actually put them in places for a short period of time.
Yep.
And
loud enough. People always say I'm loud. That we can actually put them in there for a short period of time and looking for other more appropriate accommodation. My concern is that these systems have been working really well, and the government says, well, now we hit the time frame line and we're cutting them out. So the staff that's worked in there have got to come back to the other places, and we're just wondering, well, what are we doing?
This report highly advocates for the crisis respite centres and those subacute level services to remain. Obviously, the government has already begun to pull some of the support from those services, but the consumers and carers and the sector do advocate for those services. They see the success in them.
Also, the intermediate cares, they're not being run as where they're supposed to be run.
Yeah.
They're supposed to be run for people that weren't well enough to go, were unwell, not... There were step-ups, thank you.
Yes.
There were step-ups, but now they're being used as more of an overflow.
Yes, they're
for
clogged.
casualties.
Yep, clogged was the word I was given by multiple people in this study. They said that the ICCs had become clogged with people that had nowhere else to go, and to prevent them becoming homeless, it was just easier to keep them in the ICCs. And that's definitely something that needs to be looked at by the government, how that is run, so that
we're
we
on the
can...
ground, we're getting really frustrated because we think we're doing the right thing and all of a sudden everything's been pulled back.
Yes, it is. The sector is highly frustrated by the ongoing discontinuity of funding in the area.
Oh, yeah, sorry.
And what did a lot of the clients actually say about how they felt when workers they'd been working with to help them in the housing sector and other services, when their mental health became so severe that mental health triages needed to be called, or, you know, other things like that? What did it do to the relationships? As a worker, you feel like you're breaking that relationship, but, you know, in the goodness of the client and the community, you have to make that call. But there's always that fear of, you know,
Breaking the relationship.
when you've worked so hard to build that with a
I don't think
client.
any of the clients or carers identified an issue with any of their workers breaking that relationship. It was interesting, most of the consumers I spoke to had a lot of praise, particularly for their peer workers, in that those peer workers could walk alongside them, especially when they were starting to experience signs of having another acute episode, that the ability to engage with that peer worker, someone they felt could empathise and understand, made it much easier to then have to escalate into more intense services. So I guess, again, that speaks to the values of having peer workers in the system to be able to facilitate that and prevent that breaking of relationships between consumer and service.
And thank you, Tanya. I think very...